Hi everyone, thanks for joining us for another What's New in Addiction Medicine talk. My name is Sukhpreet Clare. I'm the Associate Program Director for the Addiction Medicine Fellowship at the BC Center on Substance Use, and I'm very excited to welcome Dr. Alexandra Anghel, who's currently a fourth-year psychiatry resident here at UBC, as well as one of our BC Center on Substance Use Addiction Medicine Fellows. She completed her medical training in Ottawa, and one of her main areas of focus is the intersection of severe persistent mental illnesses and addiction medicine, which is what she's going to give us a little bit of an update on today. So a very exciting talk, and again, thanks everyone for joining us. Take it away, Alex.
Thanks, Dr. Clare. Hi, like Dr. Clare mentioned, I'm Dr. Anghel, and today I am hoping to chat with you a bit about navigating the treatment of substance use disorder and schizophrenia in the concurrent disorders population. Before I get into that, I just want to respectfully acknowledge that I am a humble guest on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations today, and just to take a moment and acknowledging where you are joining us from us today. I also just wanted to quickly acknowledge some support that I had, Dr. Elefante here at St. Paul's Hospital, and Reza Rafizadeh, a clinical pharmacist at Redfish Healing Center. I don't have any disclosures or any finance or any kind of support like that, but like Dr. Clare mentioned, this is a vested interest for me in terms of my career and things like that. So really hoping to shed some light on some things today. In terms of the objectives today, I wanted to look a bit, review the relationship between trends in terms of prevalence and epidemiology with respect to substance use in patients with schizophrenia. Also looking at the current evidence of pharmacological practices that potentially can improve outcomes in patients with schizophrenia with comorbid substance use disorder, and also just looking at something that for me has always been an area of interest, is looking at what kind of antipsychotic to choose in this patient population, looking at efficacy, tolerability, and choice in patients with comorbid substance use disorder. And so in terms of the context, the one thing that I really wanted to stress is that, schizophrenia is relatively common in the patient population. Usually we kind of, in most population studies, we've seen it about approximately at 1%. And patients with schizophrenia are more likely to develop substance abuse problems than the general population. I think there's been studies up to 50% of schizophrenia patients found to have some substance use disorder or substance dependence. And the other interesting thing that I wanted to talk a bit about was the fact that something that I noticed when I was preparing for this talk is that there's a lot of discussion of which comes first, and that's the question that's been raised in other What's New in Addictions talks as well, is is there a progression from substance use disorder to schizophrenia, or is it, after having schizophrenia you're more at risk? And really what people have noticed is that there is probably likely a bidirectional relationship between substance use problems, sorry about that, and use disorder and schizophrenia, with more prevalence of substance use disorder predating the schizophrenia diagnosis rather than the latter. In terms of rates, it varies. One of the studies that has been looking at kind of comparativeness, effectiveness of antipsychotic drugs, and looking at kind of prevalence is something called the CATIE study. It was really looking at treatment effects of a various number of psychiatric medication in this patient population, including first generation and second generation antipsychotics. There have been 2 sub-analyses of these studies that did report, in that group of patients with schizophrenia, having 87% of them having some sort of alcohol use or use disorder, 44% of cannabis, 36% with cocaine, and then another study looking at the opioid population in that group of about approximately 1.4%. Similarly, there has been a systematic review in 2018 that looked at a number of articles from 1990 up to 2017, extracting odd ratios and looking at how the authors reported that substance use A total of 165,000 subjects were yielded from this systematic review, and the prevalence of any substance use disorder, in fact, was 41%, followed by what they termed as illicit drugs, cannabis thereafter at 26.2%, alcohol 24.3%, and stimulant use at 7.3%. In terms of rates of smoking, they've actually oftentimes excluded this from prevalence studies as they find that it could significantly inflate prevalence rates. But a meta-analysis was performed in 2005 that looked at a 10-year literature follow-up. 42 studies across 20 nations looked at the association of smoking and schizophrenia, with an odds ratios always over 1 and also noting at that point that cessation rates were lower in schizophrenia than the general population. Something that I briefly touched about, and that coming back to that bidirectional relationship, is that there has been a study in 2018 looking at a Danish population in terms of conversion from substance-induced psychosis and schizophrenia or bipolar disorder. And the conversion rate was found highest to be in cannabis, thereafter thereafter for patients with a hallucinogen-induced psychosis, and subsequently mixed by other substances with, oh, sorry, my slide just went, with amphetamine-induced psychosis at around 20.2%. And so this made me wonder about what are like the impacts of substance use on treatment outcomes with patients in schizophrenia. There's been a few studies. One of the more notable ones that I found was this report done by data being extracted from a RAISE ETP study, which was looking again at treatment outcomes of participants experiencing a first episode of psychosis. And this was a participant group of enrolled in recovery after an initial schizophrenia episode early treatment program, looking at a number of community mental health agencies in the United States, and looking at tobacco smoking, alcohol, and cannabis following associating illness severity. What they noticed is that roughly tobacco smokers had higher levels of illness severity, a higher number of missed medications, like in terms of missed pills, and potentially higher psychiatric symptoms and lower quality of life, as well as the same noted in alcohol and cannabis users as well, compared to non-users. This was limited in terms of self-report measures that should be noted as well. Coming back to that study that I had mentioned, the CATIE study, looking at, again, the comparative effectiveness of antipsychotic drugs. This double-blind study looked at multiple second-generation antipsychotics compared to older agents such as first-generation antipsychotics who avoid illicit substances. And really, actually, this study showed that there was no significant differences between the different treatment arms in terms of all-cause treatment discontinuation who use illicit drugs. And among non-users to treatment discontinuation, it was significantly longer for patients with olanzapine than a first generation known as pirfenidone and risperidone and quetiapine. There were no differences noted actually with respect to illicit users and non-users in terms of symptom reduction and global improvement after there was an adjustment for differential duration of treatment. But ultimately, there has been reports over a number of years that potentially comorbid substance use disorder with schizophrenia will lead to poor outcomes in symptom management and psychiatric hospitalization, potentially higher levels of utilization of the ED service, as well as because of the challenge in general of looking at treatment of substance use disorder, given the complexity of these presentations, the diversity of substances, the multiple levels of severity in terms of their primary psychotic illness, leading to a very heterogeneous sample that is difficult to evaluate in an evidence-based manner that will be applied in a clinical setting. And that has led to treatment guidelines for this group being quite limited, as well as being actually omitted from certain RCT trials to avoid confounding factors. Nevertheless, there have been some guidelines that have been reported. The first one really that is the basis for our Canadian schizophrenic guidelines in terms of individuals with schizophrenia and other psychotic disorders with coexisting substance use are the NICE guidelines from the UK. And most recently, there has been clinical practice guidelines that were published in 2021 in Spain that I will also refer to a few times when highlighting some of the studies that they found were helpful in terms of guiding their clinical decision making in terms of treatment management. Now I'm going to switch gears and kind of look at some of the evidence for the treatment of smoking cessation in schizophrenia. Like I've already mentioned, there's a high rate of smoking. It is felt that actually nicotine may improve symptoms of akathisia and extrapyramidal symptoms in patients with schizophrenia who are on antipsychotic medications, as well as potentially helping with a key cognitive symptom that we see in schizophrenia, which is impaired sensory gating, and so the inability to actually suppress like auditory and irrelevant information that can actually improve, as well as potentially releasing dopamine in the prefrontal cortex that may lead to some improvement in terms of psychotic symptoms. And so really the Canadian guidelines actually do recommend that individuals with psychosis and schizophrenia should be helped to stop smoking, as well as even if previous attempts have been unsuccessful, given the potential impact on cardiovascular risks, as well as the metabolism of some of the of their medications as well. In terms of medications, of course, we know that varenicline and Wellbutrin are options. Varenicline is quite effective in terms of also known as Champix. But the one thing I will mention is that there is a FDA warning with respect to varenicline in terms of increase of neuropsychiatric symptoms. That would be something we would want to think about in this patient population. Furthermore, Wellbutrin is a safe and effective treatment in the general population, but there has been theoretical concerns with respect to the safety of Wellbutrin in patients with schizophrenia, as it could potentially exacerbate psychosis due to a dopamine agonism. A Cochrane review was published in 2013 looking at interventions for smoking cessation and reduction in individuals with schizophrenia. They had 34 trials, 16 looking at cessation, 9 looking at reduction, and 1 looking at relapse prevention, and 8 actually looking at outcomes for interventions that they mentioned as aimed at other purposes. 7 of these trials were comparing Wellbutrin to placebo, and meta-analysis showed that cessation rates for Wellbutrin were significantly higher than placebo than at the end of treatment. There were no reports of major adverse events with Wellbutrin, and neither any sort of increase in psychotic symptoms. Smoking cessations for varenicline were higher than placebo at the end of treatment as well, and no differences with respect to psychiatric symptoms between varenicline and placebo groups, but there was some reports of suicidal ideations and behaviors in 2 patients on varenicline. There were 2 studies as well looking at contingency reinforcement with money, looking at increasing substance abstinence rates, but this was combined with NRT, and there was no evidence of benefit for follow-up. It was quite limited. So in terms of recommendation, the one thing to consider is all of these options are great in this patient population, including Wellbutrin and varenicline, as well as NRT, but potentially also warning patients with schizophrenia about the increased risk of adverse neuropsychiatric symptoms, and particularly to monitor them within the first 2 to 3 weeks. This was also outlined in the Spain guidelines as seen below on this slide. Shifting to alcohol, in terms of treatment recommendations, neither the NICE guidelines or the Canadian guidelines comment directly on non-pharmacotherapies for alcohol use disorder in patients with schizophrenia with a coexisting substance use disorder. But it is of mention that the best evidence is for naltrexone and acamprosate with persons without coexisting psychiatric disorders. There was one study looking at acamprosate, This was a double-blind randomized control trial for 12 weeks of acamprosate against placebo. 23 patients were abstinent, were diagnosed with alcohol dependence and comorbid schizophrenia, schizoaffective disorder, or psychosis not otherwise specified were included in the study, and all decreased their drinking days during this medication treatment, but no significant changes between the acamprosate group or the placebo group. And it is of note that they looked at cognitive functioning as well, if there was any changes in this patient population, and there were none. And of note, there was a suggestion that potentially there was no effect at all of acamprosate, as this group of population was getting a psychosocial intervention as well in both groups. There's actually been a few more studies with respect to naltrexone in concurrent individuals with schizophrenia spectrum disorders. And what they've noted, this is actually a recent systematic review that was published in 2017, looking at a number of RCTs and open labels demonstrating that all actually support the effectiveness of naltrexone compared to placebo in patients with schizophrenia. And there were no safety or efficacy concerns that were elucidated in this group. And therefore, the new Spain guidelines in 2021 did recommend weekly naltrexone in terms of recommendation, for alcohol use disorder in this patient group population, but felt that potentially there was insufficient evidence with respect to the use of adjuvant acamprosate to improve psychotic symptoms, reduce alcohol use. Looking at cannabis use in schizophrenia, despite the frequency that we see cannabis use in this patient population, there hasn't been any evidence to potentially support any pharmacological treatments or psychosocial treatments for reduction of cannabis use disorder in the schizophrenia population. There was one open label trial, an RCT trial, that looked at combined contingency management with NAC in youth without psychosis that showed some evidence, but other studies looking at antidepressants or nabilone and drobenol were all negative. There's been a number of studies, and this is a very busy slide that I will kind of resume with my words here, at RCTs looking at the efficacy of antipsychotics for not only improving schizophrenia symptoms as well as cravings for cannabis use. And 3 of them looked at olanzapine versus risperidone, so 2 second-generation antipsychotics. 2 were looking at the use of a first-generation antipsychotic, haloperidol, versus olanzapine, and 1 looking at olanzapine and risperidone in hospitalized patients. In the 2 RCTs that looked at patients comparing second-generation versus first-generation antipsychotic, there was not any significant changes with respect to their psychotic symptoms in this group, or any recommendation for reduction of cannabis use. When looking at the study published in 2008 by Nimwegen, what was a 6-week double-controlled trial looking at olanzapine versus risperidone, there was a similar decrease in terms of craving for cannabis use that was found in both treatment conditions, and both were associated with improved subject well-being, with no evidence found for any sort of differential effect on subjective experience or on craving for cannabis use. In 2011, where again looking at olanzapine and risperidone, this was another secondary analysis performed on a group of patients with a diagnosis of first episode of schizophrenia, schizophreniform disorder or schizoaffective disorder, with the lifetime diagnosis of cannabis use disorder, that were either randomly assigned to olanzapine or risperidone, and the olanzapine group did not differ significantly from the risperidone in terms of changes of positive symptoms or rates of cannabis use or alcohol use in this study. And so again, as mentioned previously, the guidelines in Canada and NICE did not really recommend anything for the concurrence, but for the Spain guidelines, again, there wasn't really any recommendations based on their review with respect to recommending one antipsychotic over the other for improving psychotic symptoms or reducing cannabis use. Shifting gears again, looking at cocaine and stimulant use in the schizophrenia population. There has been 2 RCTs, again, looking at the use of a first generation versus a second generation antipsychotic, comparing olanzapine and Haldol. Both actually did show a reduction of cravings in cocaine. This is theoretically due to the D2 agonism of these substances. And of note, in one of the studies, olanzapine was associated with a greater cocaine after in their scores, but another mention was that comparing in the other study that was published similarly at the same time in 2005, they did note less motor side effects measured in the abnormal involuntary movement scale compared to Haldol. There was one other study comparing 2 second-generation antipsychotics, including olanzapine versus risperidone, but there were no group differences met in terms of symptoms of psychosis noted. And this is the study in 2006 that I had previously mentioned as well. And again, just mentioning that there was the evidence potentially of treating using like there was some evidence in terms of reductions of cravings that were associated there. The last kind of interesting study that I did find was the use of a dopamine agonist known as Mazendal. This was published in 2005 and was a 6-week trial for 6 weeks, in 24 hospitalized patients with schizophrenia or schizoaffective disorder. And there was some evidence of improving psychotic symptoms and reduction of cocaine use. There wasn't any evidence is what I meant to say. And the thing that I also wanted to mention is that this study was 8 out of the 11 subjects actually did interrupt treatment, and 8 out of the 13 of the placebo. And the graph below is just a Kaplan-Meier figure that looks at survival rates in terms of being able to extract any sort of data from. So really the difference between these groups was not significant. Dropout rates were comparable, and no subjects were actually dropped out due to medication side effects. And so again, in the Canadian guidelines, they did mention that pharmacotherapy for the treatment of cocaine use disorder is limited and no currently indicated agents for cocaine use disorder despite some trials. And interestingly enough, the Spain guidelines did recommend moderately the use of a first-generation psychotic, Haldol, over olanzapine for reduction of craving, but olanzapine would be recommended over Haldol for motor side effects, and that the use of dopamine agonists should not be recommended. When I was reviewing the literature, I didn't find any guidelines that described any sort of options for concurrent methamphetamine use and a primary diagnosis of psychosis. And this is, also difficult because of potentially there is a methamphetamine-induced psychosis that is relatively difficult to differentiate from primary psychotic disorders. And the two things, the one thing that I had mentioned and earlier on in this talk is that there definitely is some evidence of conversion from methamphetamine-induced psychosis to a primary primary psychotic disorder like schizophrenia, but there was 2 studies that I found that looked at potentially differentiating the two disorders, as well as some notable changes in terms of extrapyramidal side effects in patients with substance use, so with patients with psychotic disorders. this study was actually a retrospective quasi-experimental case control study in a medical prison in Japan, where they actually looked at behavioral problems, clinical symptoms, and equated what we call chlorpromazine, which is an antipsychotic, equivalent doses to measure how much was used in patients with persistent methamphetamine-associated psychosis and a schizophrenia spectrum disorder. And what they found in this retrospective study was that patients with persistent methamphetamine-associated psychosis were hospitalized for fewer days than those with schizophrenia spectrum disorder, but no differences in terms of behavioral problems or clinical symptoms, and that the patients with PMAP or persistent methamphetamine-associated psychosis did receive fewer antipsychotics than the schizophrenia spectrum disorder, potentially suggesting that there could be some differentiation not really based on behavior and symptoms, might be quite difficult, but response to treatment. And this was published in 2021. As individuals who work in mental health know that extrapyramidal side effects can be seen often in patients with schizophrenia that are treated with antipsychotics. And what's interesting is that we know that methamphetamine is a dopaminergic neurotoxin, and there has been some studies looking at if patients with a psychotic disorder and a substance and the methamphetamine use disorder have more EPS symptoms due to the dopaminergic neurotoxin effect. This was a study completed in 2020, and there was in fact evidence that not only that there was more EPS symptoms in patients with methamphetamine use disorder compared to ones without, but that this is dose related. So as you can see here, the graph actually increases with methamphetamine use disorder compared to the latter. With respect to opiate use in schizophrenia, again, not a lot of recommendations that I saw in the clinical guidelines, but something that I did note was that there has been theoretical thoughts that methadone might help also reduce psychotic symptoms due to a dopamine blockade effect that has been evidenced by its stimulating effects of prolactin outside of its ability to be an opiate agonist treatment. There hasn't been any sort of studies looking at comparing methadone or buprenorphine in the schizophrenia population, and it has been also reported in potentially that first-generation antipsychotics may worsen cravings due to the strong dopaminergic antagonism that is found in our reward pathway in our brains. And so I've kind of mentioned it a few times, but in terms of guidance of choice of antipsychotics with respect to a concurrent substance use, there is some studies looking at a few different first-generation antipsychotics or second-generation antipsychotics. This was actually pulled from the Spain guidelines that I was mentioning. That again, these studies I have talked about. Anghel studies a bit earlier on in this talk, but people with concurrent substance use and polysubstance use, like there has been very few RCTs available, and 3 looking at olanzapine versus risperidone as well. In these studies, what we've noticed is that potentially there may be there isn't any good quality evidence to really compare the two, but potentially that first generation antipsychotics may worsen that craving as well. Interestingly enough, with respect to long-acting injectables in schizophrenia, it has felt that given some of the complex presentations that we can see in this group, that and like I mentioned, some studies have shown a history of non-adherence, that would long-acting injectables be helpful in this population. This is a systematic review that was completed in 2021. I am so sorry, I keep messing us up. And in this study, they were able to find 8 reports, 1 case study, 1 case series, 3 open label retrospective studies, 3 randomized control trials looking at the use of long antipsychotics in 357 patients with schizophrenia and substance use disorder, with 5 of the studies looking at alcohol use disorder, 5 of the studies looking at cocaine use disorder, 5 of the studies looking at amphetamine use disorder, and 1 study looking at cannabis use disorder as well, that were all included in the systematic review. And it was felt based on these, I just on this slide have the RCTs noted, but that they did have some evidence that this may be a good intervention for this treatment group, but due to relatively small sizes, that as you can see in the effect sizes in this table, and the heterogeneity of samples, as well as substances of abuse and really different long-acting injectables and their comparison as being quite different, it's hard to really, I would really consider these as preliminary and to be interpreted with caution. But there potentially may be evidence for ongoing research in looking at the effects of long-acting injectables with patients with schizophrenia and substance use disorder. And so again, there was a moderate or weak recommendation in the Spain guidelines, the use of second-generation antipsychotics over first-generation antipsychotics, and then again, a weak recommendation for olanzapine over second-generation antipsychotics. The last part of this presentation is I wanted to look at something that came up quite a few times in my readings, was the use of the medication of clozapine. Clozapine is the molecule that you see here. It's an antipsychotic that we reserve mainly for treatment-resistant schizophrenia in psychiatry, but there has been a number of articles over the last, I would say, 2 decades that suggest potentially this is a molecule that we could, that there is positive evidence for patients with substance use disorder and schizophrenia. And in fact, this hypothesis is why sometimes in the studies that I've mentioned before, they used olanzapine as a comparator to risperidone, as olanzapine is quite slightly similar to its molecular structure. As some of you may know, clozapine is kind of, it's a good medication for treatment-resistant schizophrenia, but issues are, it needs to be taken every day. We do require, with initiation, we do require quite a bit of blood work monitoring as well, and there are some side effects that need to be taken in consideration as well, that in terms of this medication as well, which is monitored with the blood work initially when starting this medication. In terms of, as you can see here, compared to other first generation and second generation antipsychotics, there's a lot of different receptors for, including a dopamine D2 receptor, as well as blocking of the serotonergic 5-HT2A receptor, seen here as the big one on the left, and as well as the noradrenergic 1 and 2 receptor. All of those receptors that I just mentioned, I know they're big words, but they have potentially been associated with reduction of substance craving. There has been a theory that clozapine reduces the euphoric features of and psychotic symptoms of some substances, and what is felt is that potentially, furthermore, is that there is less cognitive side effects with this medication compared to first generation antipsychotics and other second generation, and similar to other second generation antipsychotics, and potentially, the use of this medication in patients with concurrent schizophrenia and substance use disorder may allow them to enable to engage in more psychotherapeutic treatments of substance use disorder. A systematic review that was completed in 2017 looked at the use of clozapine in patients with schizophrenia, and this was published in 2017. In terms of the selection process, there was a wide search of databases, and particularly full text articles were assessed for eligibility, and articles that were excluded were the cross-sectional, observational, and case reports. Eventually, this actually only led to 14 articles, 5 of them looking at nicotine use, and 5 is being amalgamated to other substance use other than nicotine. When looking at clozapine and nicotine in this systematic study, the sample sizes actually ranged from 12 to 300. There were 3 RCT trials that were noted, and 2 open label studies. In terms of comparators, first generation antipsychotics and non-clozapine second generation antipsychotics were used as a clozapine comparator in 2 studies, and then for the other 3 studies they actually looked at different doses in terms of low and high for clozapine, but none actually used placebo as a comparator. In terms of measures that they used, there was subjective and objective measures for studies looking at nicotine and clozapine, and that included self-reported nicotine use by how many cigarettes they smoked a day, as well as a Fagerstorm test for nicotine dependence, and expired carbon monoxide and a metabolite found in our blood after smoking, cotinine plasma, was used in these studies as well. But in terms of using this, the evidence for using these are not great, so that's something to mention as well. When clozapine was compared to first generation and non-clozapine second generation antipsychotics, there did seem to be a reduction in self-reports of smoking and expired carbon monoxide in 2 of the RCTs. But when evaluating clozapine with and when evaluating it with other adjunctive smoking reduction treatment like NRTs, this was superior to non-clozapine SGA, but second generation antipsychotics, but not superior to first generation antipsychotics in terms of the subjective tests of nicotine use. The one thing to mention, and also the 2 that looked at comparing, the higher doses versus clozapine, is that there was a higher amount of individuals that decreased smoking use after 12 weeks at higher doses of clozapine rather than lower doses. This information does, these studies have limitations, in particularly that can affect the validity of this. First of all, as some of you may know, smoking, not nicotine, in fact, actually reduces clozapine plasma levels. And so this has led to potentially a psychiatrist might be prone at tailoring clozapine dosage based on how many cigarettes that patient is smoking. Whereas also potentially patients may be motivated to stop smoking if they know that they won't need as much clozapine as well. This also studies have recruited long-term hospitalized patients where there has been an act, like a lot of the times we do restrict smoking on inpatient facilities, and so that would be difficult to kind of extract that data for the community as well. And most of the studies didn't control for potential confounders such as age, gender, or clinical features, side effects, or smoking severity as well. When looking at clozapine and other substances, only 21 were noted to be for the study, and only 9 met the inclusion criteria. 3 of them were RCTs, 4 of them were prospective studies, and 2 of them were open label. 7 of the studies, interestingly enough, were performed in an outpatient setting, and main clozapine comparators were, again, first generation antipsychotics, risperidone, olanzapine, and ziprasidone. And in terms of what substances were most commonly studied with the use of clozapine and treatment is cannabis followed by alcohol. RCTs actually did show some superiority of clozapine when compared to a second generation antipsychotic of risperidone in short-term studies ranging from a month to 3 weeks performed in cannabis users in terms of cravings as well as reduction of their cannabis use. And in long-term studies, it was noted that clozapine was actually equal to ziprasidone in terms of reducing cannabis use and equal to treatment in terms of reducing alcohol use. In terms of evidence of clozapine on substance use disorder, other than nicotine, it was felt that this evidence was stronger, especially when comparing clozapine to first-generation antipsychotics with people that used multiple substances. Again, limitations. Outpatient was the target population, and of course, this approach may be closer to real-world clinical practice, but this could lead to a selection bias, as prescribers may be selecting patients that they feel can engage in clozapine treatment due to less severe psychotic symptoms. This was mentioned in one of the articles, and potentially having a less degree of severe substance use as well. And again, confounders were not evaluated. Oftentimes, most of the subjects were male in most of these studies as well. And in clozapine with other substances use, there wasn't actually any objective measures. It was primarily self or clinician reported measures. So I know I've bombarded with you a lot of information, but there were a few key points that I wanted to really let you guys know. For a number of decades at this point, the co-occurrence of substance use in the schizophrenia patient population has been investigated with a number of population studies, and that there has been the suggestion of not necessarily one causes the other, but that there is a bidirectional relationship between schizophrenia and substance use, and that really the impact of treatment outcomes amongst patients with schizophrenia with substance use is mixed, but there is some moderate evidence of increased mortality, morbidity, and complex presentations. Smoking cessation in the schizophrenia patient is recommended, and the current evidence is highest for varenicline. In patients with alcohol, there is some evidence of the use of naltrexone compared to other agents. With respect to cannabis use, there wasn't any recommendation in terms of choosing an antipsychotic in terms of improving psychotic symptoms or reducing cannabis use. And really the pharmacotherapy for the treatment of cocaine use disorder is quite limited, with no agents really recommended. Patients with schizophrenia and opiate use disorder should definitely be approached with a dual diagnosis outlook and definitely address both disorders equally, and that there is some weak and moderate evidence of potentially choosing second-generation antipsychotics over first-generation antipsychotics, and some evidence of potentially choosing long-acting injectables in this patient population, and as well, more research definitely needed, but the use of clozapine in this patient's population as well with schizophrenia and substance use, including smoking cessation. That's the end of my talk. I'll leave it up for questions now. Thank you so much for your attention.
Thanks, Alex. I'll give everyone a minute if they want to type out their questions in the chat, or if they want to be unmuted, you can raise your hand as well, I think. Not seeing any questions immediately. One thing I was curious about is I've seen, you mentioned that there's some evidence for the use of second generation antipsychotics. I've somewhat seen a few psychiatrists actually mention trying to avoid aripiprazole in patients because of a potential warning of increased impulsivity, particularly with sort of comorbid stimulant use. I wonder if that's something you've seen, or if you have an opinion about how to navigate that situation, if you think there's enough to say one way or the other, and if that's an effect that's unique to Abilify, or if it's applicable to other agents as well.
Thanks for your question. I guess in terms of from the Abilify, it does have that warning of increased impulsivity, but I hadn't seen anything in terms of I definitely have heard that as well, more of like a clinical practice that I've seen, but not necessarily something that I actually did come across. I think there was, I don't actually know if I saw any with aripiprazole, except maybe one long-acting injectable that was compared to another long-acting injectable, but nothing that really like blaringly came out to me about that. Yeah. I guess the one thing to think about is in patients with, there is in aripiprazole about a 10% chance of akathisia, which is related to EPS symptoms. So definitely kind of something that I think about, as well as potentially like individuals that are using methamphetamine having more of that EPS symptoms as well. That would something I'd consider with aripiprazole.
This may not be sort of like a specific answer, but I've always been sort of curious, like how to navigate the challenge with recognizing that for a lot of these patients, clozapine may be the most appropriate medication, but obviously comes with the most difficult challenge. And if you've sort of in your years of training sort of come across some conclusions or some thoughts about how to balance trying to use potentially a very sort of specific medication that has lots of additional considerations in a population that is potentially the least likely to be able to complete the sort of requirements of monitoring and titration? Or is it just a challenge that you and I can both complain about?
No, I mean, I guess that isn't, this is more of my opinion in that sense, but I did do some work at the Redfish Healing Center and worked with people with severe mental illness and concurrent disorders, and a number of like complex like multiple substances. And I think part of it is like having the luxury of time as well, for the patient to improve, as well is a big thing. So I guess that's the one thing, is that if you have the luxury of time to get them on that medication, to spend the time that the team is able to engage them and provide psychoeducation in with the use of clozapine. A lot of the times, actually, this is one thing I will say. One of the things that has come up quite a few times with patients that I wanted to start on clozapine is that they don't want to get blood work. They don't like needles, they hate needles, they're afraid of needles. And so I guess one of the companies, and I am really forgetting which one right now, has actually created this point of care like blood test that you could do. So it would be a pinprick for that. And we I don't think I don't think Redfish has one, or I don't think here at St. Paul's we have one either, but that's something that I'm hoping will become more available. And then obviously that would lead to, because I mean, even in an outpatient setting, it is tedious to get to, especially in our patient population, to get to like a life labs and things like that. So if there was like, at their mental health team, they were able to just do like a quick pinprick and that was it, like would that lead to improved adherence? But yes, definitely very challenging in this patient population because of the evidence for non-adherence as well, and obviously the risks of like when starting at like myocarditis, agranulocytosis, et cetera, that we do need to monitor. But I am somewhat hopeful for the future.
Awesome. Yeah, that'd be an awesome change. So then I don't see any questions in the chat, so I'm gonna let you get on a soapbox for a minute if you want. As an expert in this interface of severe refractory psychiatric conditions with comorbid substance use disorders, what do we need to do as a system of care, or what changes would you want in an ideal world that you think would benefit this extremely vulnerable group? What do you want to see the system do?
I think in general, we need to, I think it's a hard question. I think ultimately more education of like just how prevalent it is in mental health, like from like sorry, I feel like I'm fumbling my words, but what I'm trying to say is I think one of the things that I'd like to see is just overall more like integrated substance use and mental health care, like throughout like different levels of care. Obviously, you know, tertiary care, we have that, but how can we incorporate that a little bit more at like community hospitals, smaller settings and things like that is something that I've like thought about. I don't necessarily know how to do that, but I thought maybe part of this talk would be kind of having talks like this and educating just the general population if there's any considerations we need to make, and really definitely thinking about when treating someone with a first episode of schizophrenia is looking like doing a substantial substance use review and monitoring that and how to best support them with motivational interviewing early on in their schizophrenia spectrum illness, because as I've seen just from my own clinical experience, that will become harder and more difficult to engage when they are later on in their illness.
Awesome. Well, hopefully we can try to get there. I don't see any other questions from the audience. If you have anything else you want to say, please do. Otherwise, we can thank everyone for joining us and get out of here.
Well, thanks for having me and hope everyone has a good day.
Yeah, thank you for such a great talk. It was really nice to see this update and see all this information and see all the areas that we still don't know a lot about, but you know, awareness is obviously a very important first step. So thank you very much, and thanks for everyone for joining us today, and we'll see you next time.